Hi, good afternoon, everybody. It is 5 p.m. in Paris, 4 p.m. in London, 11 a.m. in New York. And it is my great pleasure to welcome all of you to this new journal club by the International Academy for Clinical Hematology. I'm sure you're now becoming very familiar with the IACH journal clubs, which are brought to you twice per month. I'd like first to acknowledge the generous support of Takeda Oncology through an unrestricted educational grant to these journal clubs. For today's journal club, the Scientific and Steering Committee of the IACH has selected this paper recently published in Blood Advances, and you can see the title, the Simplified Comorbidity Index, a new tool for prediction of non-relapse mortality in allogenic hematopoietic cell transplantation. And we have the great pleasure today to have Dr. Roni Shouval, who is the first author of this super paper, to be one of our panelists. Roni Shouval is an attending physician in the BMT service in New York at the Memorial Sloan Kettering. And the other panelist, who is another top expert in this field, is Dr. Nicola Polverelli, who is also a highly regarded transplant physician at the University Hospital of Brescia in Italy. So this work, you can see the summary here, and obviously I'm not asking you to read it. It is a quite important number of patients, a cohort, a single center cohort of 573 adult patients who underwent CD34 selected allotransplant. This is very important, guys. Just stay with me. Myeloablative conditioning, another important piece of information. And the authors attempted to develop, and actually they managed to develop a so-called Simplified Comorbidity Index, the SCI, where they could identify 4 major comorbidities which are predictive of non-relapse mortality after a transplant, as well as relatively older age, above 60. And when you look to the results of non-relapse mortality correlated with individual comorbidities, you can see on the left-hand side that the renal function is apparently the strongest, I think, comorbidity that is impacting non-relapse mortality, followed by moderate, severe hepatic dysfunction, severe pulmonary, composite cardiac, etc., etc. And you can see these interesting cumulative incidence curves of non-relapse mortality looking into these different comorbidities and their impact, whether you look to the pulmonary, the liver, but also to age. And this is how the authors, Dr. Shouval and colleagues, have defined actually the Simplified Comorbidity Index, and the score they have assigned at the end of the day. Moderate to severe renal dysfunction received a score of 3, mild renal dysfunction 2, moderate to severe hepatic dysfunction 2, and so on. And at the end of the day, they ended up actually with a very nice separation of non-relapse mortality rates based on the Simplified Comorbidity Index. And another important piece of information is that they were able to validate these results in an independent transplant cohort from the Sheba Medical Center. And here I'd like to say a big hello to my friend and the co-chair of the IACH, Professor Nagler, who is the leader from Tel HaShomer and Sheba. So with this, I'd like to start the discussion with our two panelists. And please, as you know very well, this is a highly interactive activity. And please do not hesitate to send your questions using the Q&A icon or the discussion, and I'll be more than happy to share your questions and comments with the panelists. So as it is the tradition, my first question is to the non-co-author of the paper, so to you, Nicola, and I always ask the same question. What was your impression, your reaction when you read this paper, when you've seen it published, and you have worked a lot, you have a nice track record of publications in this field of comorbidities. So what was your reaction, Nicola?
Thank you, Mohamad, for this question. I think that this paper, in my opinion, is one of the most relevant publications in this topic over the last 20 years. I think it's a nice paper who would allow us to very effectively stratify patients at higher risk for non-relapse mortality. And I think that in our clinical practice, it would be very important to adopt such kind of score. We all of us are very aware about the large amount of patients we manage, and having simply a score is very important to me.
Okay, so in general, it looks to me that you are very positive about it. So
Yes.
My next question to you, Roni, and congratulations for this nice work. Actually, so my role is to be a little bit the devil advocate for Roni, and I would say that in 2005, Dr. Mohamad Saror from the Fred Hutch has published really a seminal paper in Blood about the Charlson Comorbidity Index adapted or adjusted to stem cell transplantation. And I think we've been using it in many studies, in many centers, and I believe there have been a lot of publications validating it. So my question to you, Roni, here, a little bit provocative, why did you have to do this work while we had, in theory, a nice validated comorbidity index in the field?
Well, thank you, Mohamad, and thank you so much for the invitation. I'd also like to thank all my co-authors that helped with the analysis in the paper. So I think, what prompted us to do this study was actually, there are several causes. First, as you alluded to, the HCT is a very useful tool and been extensively validated, and it really was an important contribution to the field. However, we must acknowledge several points. The first is that the comorbidity, the HCT, was developed on transplants performed at a single center 2 decades ago. This was a mixed cohort of both myeloablative reduced intensity conditioning, and obviously a lot has changed in the past 2 decades. We know that our patients changed, the transplants changed, and supportive care changed. So what was relevant then, which was based on the Charlson Comorbidity Index, might not be as important, or the weights of the different comorbidities could have changed over time. Now, other considerations that we took into consideration, I would say, is that we know that the ACTCI, while validated, it does have variable performance across different cohorts. And there could be different reasons for that, whether it's just cohorts that are different from the development set, but also, as we alluded to earlier, there was change in the profile of our patients. The third reason is that the influence of comorbidities has also likely changed over time, right? But at the time that the ACTCI was developed, peptic ulcer disease was assigned as a significant comorbidity. However, I think that most of you or all of us would agree that today peptic ulcer disease is sort of a minor comorbidity and should probably not be weighted into the score. And the fourth point I would say is that we saw that one comorbidity that is specifically important is the renal comorbidities or chronic kidney disease, where in the HCTCI, the threshold for kidney disease was a creatinine above 2, while we know that a minority of our patients is actually transplant with a creatinine above 2. I mean, this is a very sort of restricted population, while we have better or more sensitive measures to evaluate kidney function, such as the estimated glomerular filtration rate, which we thought would be more sensitive in capturing renal comorbidity in this population.
Excellent. Thank you very much. I think you provided some convincing argument. Nicola, so can you comment? I think Roni, for instance, just alluded to the fact that the degree of renal dysfunction, for instance, was among the strongest predictors of non-relapse mortality. What explanation do we have for this? Why kidney dysfunction is actually would lead to toxic death in these patients?
I think, of course, it's mainly due to the use of calcineurin inhibitor that are very commonly used as GVHD prophylaxis in such patients. And of course, the platforms are changing over time, and I think maybe in the future these could change again and again. So maybe with cyclophosphamide, post-transfer cyclophosphamide, we can change also this aspect. This is my opinion, of course, and I don't know if Roni has another one.
Yeah, thank you, Nicola. So I agree. I mean, one possible explanation is a calcineurin inhibitor. Although when we developed the data as a score, we developed it on a patients receiving CD34 selected transplant, which are calcineurin inhibitor free. So our assumption was actually that if you have a patient with a kidney dysfunction, then he would probably benefit from this sort of transplant, which did not seem to be the case, because the cumulative incidence of non-relapse related mortality in patients with an eGFR below 60 was approaching or approximately 50%. So these patients, from our data, suggest that actually sort of myeloablative conditioning with CD34 selected is probably not the best platform for these patients. I do think that this would definitely, I would definitely argue that patients with a renal dysfunction, we should consider really other alternatives than calcineurin inhibitor, GVHD prophylaxis, and PTCY does seem to be a promising avenue, but needs to be evaluated, I think, separately. Overall, you know, eGFR or the renal function is a good function. It's a good measurement, I think, of the functional reserve of the patient, and it's probably one of the function that is most reflective on the burden that the patient had to date. So, right, we know that exposures, for instance, to platinum-based therapies, to methotrexate, could take their toll on the kidney. And I think this is sort of what we're seeing.
I mean, my personal feeling is that when you have a poor kidney function, actually, at least when we use calcineurin inhibitors for prophylaxis, you're not able to deliver effective GVHD prophylaxis. Then you have acute GVHD, especially in the gut. You initiate corticosteroids. So you start a vicious circle. Corticosteroid, you have CMV reactivation and other opportunistic infections. You would go for ganciclovir. You've got cytopenia, and it's going to be a vicious circle. That's my clinical feeling, but definitely this is proving very important. One question is about age, I think, and I would like to hear both of you, your opinion. I think you arbitrarily chose Roni age 60. So one may wonder, why is it 60 and not 65 or not 55? Obviously, I know in the transplant field, you know, the limit of the so-called elderly patient keeps on increasing these days, but why 60?
Yeah, that's a good point. And to be honest, I don't have a very good answer. That we just needed a threshold, something that would be useful in the model, and this is sort of the go-to number in many of the cases. Also, we must acknowledge, I mean, this was a population that received myeloablative conditioning. So, you know, we had sort of limited flexibility to how high can we go or how low could we go. So we thought that 60, based also on sort of clinical judgment, is a good number to choose. However, you know, you raise a point that maybe, or the best way to go is actually looking at continuous. So thinking of risk and the features going into the model as continuous covariates, rather than have some sort of arbitrary or statistically set threshold. So we may have more information in the when considering comorbidities of physiological function as a spectrum.
Actually, what's behind my question, and I'd love to hear from Nicola, is that since you focused on myeloablative conditioning, I mean, for me, at least in our experience, it's quite rare to give a myeloablative conditioning above age 60. So this is why I was thinking more about something around 50 to 55. What do you think, Nicola?
I think that we should shift from this opinion. Maybe in the future, maybe we should tailor the conditioning platform according to disease specific and patient specific characteristic. I think that some patient older than 60 may have may be more resilient to conditioning myeloablative conditioning regimen than expected in the past, because we have new tools for dissecting or patient with different functionality and comorbidity. So I really appreciated your work, Roni, because we now have a new tool that we can integrate in a simple way with the other tool for managing, in particular, elderly patients.
Excellent. So thank you, Nicola. We have a question here, a couple of questions, maybe this one to you from Dr. Virgilio Alberto Salinas Rodriguez. I hope I'm pronouncing it well. Where would you consider liver steatosis or hepatic fibrosis in terms of risk, for instance, if you have such patient in your scoring system?
Yeah, so we coded the hepatic dysfunction based on the score assigned in the SOAR score. So we did not change any definition, and that's sort of part of the utility. I need to go back to the paper and see where does hepatic steatosis fall or hepatitis fall, if it's included in the paper. I think that one of the problems, right, when we're actually looking at the definitions of comorbidities is that sometimes it's subjective. So it's very difficult to define whether a patient actually has a comorbidities or does not have the comorbidity. And one potential application, I mean, one potential implication of that is actually maybe it's better to go on actual objective measures where you have, looking at continuous covariates of laboratory measurements in setting the comorbidities. But I think, for instance, hepatic steatosis, you may have different assessments, since it's kind of user or operator dependent, the ultrasound, you may have different classifications by operator. So it's essentially the same classification that you would have in the SOAR comorbidity score.
Wonderful, thank you. Maybe this one for you, Nicola, and this is from Dr. Eleni Gavrilaki from Greece. I will put it in a broader perspective, and if we stay in this issue of moderate to severe hepatic dysfunction and its impact, could this be related actually to the endothelial damage and then its corollary of severe veno-occlusive disease, which we know is usually quite highly fatal outside treatment? Of course, can you comment on why the liver dysfunction is such a strong predictor immediately after kidney?
I think that all these aspects maybe should be related to toxicity occurred before transplantation, and they can reflect the patient resiliency, as I said before, to the toxic effects of chemo and transplant-related complication. I think it's very complicated to assume a specific, how can I say it, a specific relationship within renal and hepatic disorder. I think that altogether, these items reflect the resiliency of the patient, of the transplanted patients.
Excellent, thank you. Roni, we have a question from Dr. Panayotis Kaloyanidis. Again, I hope I'm pronouncing very well, which is about the role of Karnofsky score or performance status. I think in one of his subsequent publications, Dr. Soror has further refined actually the comorbidity index with the performance status. So did you take this into account in your evaluation and your analysis?
Yeah, thank you. That's an excellent point. So in the multivariable analysis, we did adjust for the performance status. However, my bias regarding performance status is that it's very subjective, and two transplanters may look at the same patients and assign a different performance status. So that's why we were actually hesitant in including it into the model. But I think that, as we all know, above comorbidities, above all these scores, it's a matter of a lot of times seeing the patient as a performance status, which is not necessarily evaluable every time by number, but as we see the patient, sit down or stand up from his chair or the examining bed, this is likely one of the most important features, when determining the risk of a patient of having non-relapse related mortality and toxicity.
Okay. Any thoughts on this, Nicola?
I think that Karnofsky is very subjective. I think I totally agree with you, Roni, and I think that we can overcome such kind of evaluation with the novel tools.
Okay, so one last question about the different comorbidities before moving to another category of questions I have in mind and we're receiving. So we have a comment from a member of the audience asking, what happened to the other malignancies, which we know in the initial score by Soror, they had a big score. You know, if you were treated for melanoma 10 or 15 years ago, that would give you a lot of points. Here, where does this fit, especially that now we have more and more patients, you know, who are treated for 2 or even 3 malignancies, unfortunately. But the good news is that we're able to keep them alive and treat them, which is, of course, quite good news.
Yeah. So when we did the analysis of comorbidities or a comorbidity level analysis, prior malignancy did not meet statistical significance. That being said, I agree, it's probably an important feature. The problem is the heterogeneity in prior malignancies, and that's exactly to your point, Professor Mohty. I think that, you know, if prostate a carcinoma that was resected and did not require any systemic therapy 10 years ago is likely not a meaningful comorbidity in these patients. So a prior malignancy should probably be redefined, I would say, to better capture it. But you know, if a patient's obviously got chemotherapy in the past, that's probably for a different type, for breast cancer, for instance, that's probably more meaningful. So it's again the problem of the heterogeneity in the definitions.
Excellent, thank you very much. Here I have a question maybe for you, Nicola, and this is from Professor Didier Blaise from Marseille. Hello, Didier, and thank you for following this journal club. We're very proud having top expert like yourself watching this journal club. And Didier is asking a very good one about how do you feel the correlation between this new score by Roni and colleagues and the geriatric evaluation one would do in elderly patient. I know in this cohort, these were mainly myeloablative patients, and the median age was relatively younger. But how do you feel because I think you published a few papers on geriatric evaluation and so on. How do you think this would fit? How do you reconcile these two things?
That's a very good point, and I think that I would work on this in the next future. I think that we have to manage this score in the geriatric context in order to assess its validity in this setting. I think that geriatric tools may be not alternative, but can be integrated with the comorbidities in order to allow a better prognostication. So
you view them as synergistic and not...
an integration, synergistic. Also, if I can, I would like to add something about the previous question. I think that the primary comorbidity index over time was dramatically affected by medical advances, and I think that a lot of comorbidities that were very important before, such as malignancies, of course, maybe now are less important because we have a lot of effective treatment for those patients with such kind of comorbidities. We have to think about diabetes. We have a lot of novel drugs, and we can allow more diabetic patients to reach transplantation with a good blood glucose level, and we can reach a complete remission from other malignancies. So I think that the majority of comorbidity we lost in this paper may very good reflect the advances in medicine. This is my opinion. I don't know if you agree with me, Roni.
Yeah, I totally agree that management has changed, and obviously diabetes now is not diabetes 20 years ago. I would also say, but to be sort of on the other side of the discussion, would say that this is a biased population, so there is definitely selection bias here, and the fact that the patient goes into transplant means that, you know, he's probably in a myeloablative transplant, means that he's probably meeting a threshold that even despite the comorbidity, he's probably at a better state than someone who would get non-myeloablative conditioning or be selected to other, or not even receiving transplant. So we should always keep that in mind and be cautious whenever we're evaluating these scores and comorbidities. Obviously, bias here is a factor to consider.
Yeah, thank you, Roni, for highlighting this. Here, I'd like to share a comment. It's not a question, but I think it's a nice comment from Dr. Federica Gianotti from Geneva in Switzerland, who is suggesting that maybe due to the younger age of this cohort, the other malignancies did not have an impact. And I think Federica, who's our friend, made a nice, it may be a good explanation, I think. Let's move, Nicola, to one important question we have from the audience is about, can we immediately extrapolate these findings into the reduced intensity conditioning setting? Because we know these days that, at least in many centers, the majority of the patients are receiving as a so-called reduced intensity or reduced toxicity conditioning regimens. So would you be ready in your practice today to use this simplified comorbidity index in a patient who is 66 and who's going to receive fludarabine, intermediate dose of busulfan, and ATG, for instance, as conditioning?
I think that these need to be clearly proven. I think the data, the available data are not sufficient to widely adopt this kind of tool for all patients. But in the future, I think that we should make any effort to validate this prognostic model also in a reduced intensity conditioning regimen. I think that elderly subjects are a very different population, and this is a setting where we need to integrate comorbidities to geriatric assessment, and I think that in the future we will have some important data on this.
Roni, would you agree with Nicola, or you think your score can be immediately applied to the reduced intensity setting?
Yeah, so after dealing with scores for quite a while, I'm always cautious when seeing a score, and even my score. I think it's always better to validate both consider even the HCT-CI, by the way. There is great variability across centers. And for instance, when we tested the HCT-CI, which was commonly used at our center for many, many years, right? It didn't, its ability to discriminate between high and low risk was not as good maybe as one would expect. So it always requires validation. And I would say that centers should always, especially if they're making clinical decisions based upon these scores, they should test them in their population. But going back to your question about reduced intensity and reduced toxicity conditioning, we did do a validation, external validation in the Sheba cohort. And then again, I'd like to thank Professor Nagler and Professor Shimoni for collaborating with us on that. And that was a mixed population receiving fludarabine and treosulfan, which is kind of, if we're thinking about sort of a intensity, especially considering the NERD tools to classify conditioning intensity, the TCI, right? It's somewhere in the intermediate level, and we had fludarabine and melphalan there. I mean, the score was discriminative in that population, and again, to a greater extent than the HCT-CI, but that was a relatively small cohort, about 230 patients. So I think we still need to validate it in a broader population. And I think even in the myeloablative conditioning, I would like to see the score tested in other populations not receiving a CD34 selected transplant, but across the board.
Well, okay. Now let's. The message is quite clear. Let's move now to another set of questions, which about how to use actually these comorbidities and its prediction. So in another way, my question to both of you, if in a high risk or even relapse acute myeloid leukemia patient who is age 55, and we know the dismal outcome outside transplant, the life expectancy is going to be reduced, in this patient. But then your simplified comorbidity index is telling me, oh, this patient, I can predict a high risk of non-relapse mortality. Does this mean I should not do a transplant for this patient, bearing in mind that the outcome of the relapse refractory leukemia is terrible? Or is this about guiding or allowing to optimize a sort of a gentle transplant approach? What are your thoughts about the practical use of these comorbidity indexes? Who wants to start?
Nicola?
Okay, but I would say definitely the second option, but of course it depends on different aspects. I think that if you have a very elderly patient with a high-risk disease, but very high risk of non-relapse mortality, maybe this can lead to avoid transplantation. In other ways, I would say that this tool could help physicians to have a gentle approach to this patient for consulting better transplant candidates. I think that the second option is more reliable, in my opinion.
But Nicola, my question was about not the elderly patient. My question was about the 55 years old patient.
Yeah, I would say definitely
what would
the
be
second
your
option, of course. I would try to have a better approach to reduce toxicity.
Roni, what's your approach?
Yeah, so I think that one thing to consider is that, right, we did not compare here the alternative arm of not transplanting the patient or giving sort of another therapy. So we're restricted in in the landscape that we are considering. But as sort of a principle, I think this tool is really focused about the patients that we are transplanting and would suggest to modify perhaps the treatment based on what you see, or maybe modify the intensity based on the expected non-relapse related mortality. And it's both considering the score itself, but I think the logic here also should always work. And for instance, we saw that high renal or renal dysfunction, severe renal dysfunction, is associated with dismal outcomes in our patients. So I think now that we are seeing a patient that looks terrific, but his EGFR is 60, irrespective even of the score, we were kind of thinking, well, not all comorbidities are created equally, and we should consider both the score, but also the comorbidity and obviously the patient. So in my mind, this is a tool that helps us make decisions. I would say that it's more restricted to actually patients that we are thinking of transplanting. And based on that, we may want to modify, the interventions, whether it's a GVHD prophylaxis, whether it's the intensity.
Excellent. So we're reaching almost the end of this journal club, and I usually always ask the same question to both panelists at the end. So I'll start with you, Nicola. So based on this work, based on what has been published in this field, what do you think would be the next step? If I give you a grant today, what kind of studies, protocols, research you would like to do in this field to further advance this field?
As I mentioned before, I think that integration is the future. I think that this score could be integrated in the other tools we have, particularly in order to assess functionality of the individual, psychosocial aspects, social environment, and so on. We have to put everything together in order to for a better prognostication. This is my opinion for the future development of such scores.
Excellent. Roni, what's the next step after this work? What are you doing now?
So I think we should divide the answer to two segments. One would be sort of thinking about retrospective, I would say, versus perspective. And in the retrospective field, I would argue that first we need to validate the score externally and maybe tune the weights, right? Because in reduced density conditioning, the comorbidity's impact may change and we may need to adjust it or recalibrate it. So validation is one. In the sort of retrospective domain, I would also think that we need to have, again, develop more accurate tools that would provide us better prediction. And the way there, I think, is to capture, have sort of a non-parsimonious approach or unbiased approach when capturing data on our patients, and also trying to go to objective data as much as possible, rather than have fields that are coded by physicians or whatever. So take the ejection fraction, take the actual pulmonary function test, and not just the categories, laboratory markers, etc. And then on the sort of how to deal with it prospectively, I think that, or in clinic, I think what I would like to see is have intervention-based trials where we modulate the elements in the transplant, GVHD prophylaxis, conditioning, based on the comorbidity burden of the patient. So that's sort of how I would like to see that in clinic, to see that it actually makes a difference in the management of our patients.
Sort of a dynamic use of these comorbidity indexes. Well, this is really fascinating, very exciting. We still have a lot to do, but I think, again, Roni, congratulations. This work is a nice step in the right direction. And now we need to continue this work to further try to improve the outcome of allo-transplant patients. So with this, I'd like to thank you both for your contribution, for accepting our invitation. I'd like to thank all the colleagues who attended, who followed, who sent their questions. I do apologize that we could not take all the questions, but we have a limited amount of time. But I'm sure you can reach out to Dr. Polverelli or Dr. Shouval, who will be very pleased to answer your specific questions. But for the time being, as usual, wherever you are, please stay safe and keep well. Take care.